This is Chapter 10 of the ATI Maternal Newborn, Early Onset of Labor. Understanding the importance of identifying the onset of early labor in a client who is pregnant is crucial for maternal and fetal well-being. This chapter includes preterm labor, pre-labor rupture of membranes, and preterm labor rupture of membranes. Preterm labor is uterine contractions and cervical changes that occur between 20 and 36 weeks and 6 days of gestation. Preterm labor can be categorized as very preterm, which is less than 32 weeks, moderately preterm, which is 32 to 34 weeks, and late preterm, which is 34 to 36 weeks. Shorter gestation is associated with increased neonatal risks. Risk factors: infections of the urinary tract or vagina, HIV, active herpes, or chorioamnionitis, infection of the amniotic sac. Previous preterm labor, multifetal pregnancy, smoking, substance use, violence or abuse, lack of prenatal care, low pre-pregnancy weight, and advanced maternal age. Expected findings is uterine contractions, pressure in the pelvis, and menstrual-like cramping, GI cramping, sometimes with diarrhea. Physical assessment: increased change, odor or blood in vaginal discharge, change in cervical dilation, regular uterine contractions with a frequency of every 10 minutes or greater, lasting 1 hour or longer, pre-labor rupture of membranes, and discomfort, dull lower abdominal pain or back pain. Lab tests, is fetal fibronectin, cervical cultures, CBC, and urinalysis. The diagnostic procedures: obtain a swab of vaginal secretions or fetal fibronectin. This protein can be expected during early and late pregnancy, but presence between 24 and 36 weeks, 6 days, can indicate inflammation, which increases risk for preterm labor within the next 2 weeks. FFN testing combined with cervical measurement is the best way to determine risk for preterm labor. Measure for a shortened endocervical length with an ultrasound. Cervical shortening occurs before uterine activity or contractions, so this can be a predictor of risk in conjunction with other findings. Cervical length greater than 30 millimeters indicates low risk of preterm labor. Obtain cervical cultures to check for presence of infectious organisms. Culture and sensitivity results guide prescription of an appropriate antibiotic if indicated. Perform a biophysical profile and/or a non-stress test to provide information about a fetal well-being. Patient-centered care. Management of a client who is in preterm labor includes focusing on stopping uterine contractions. Activity restriction. Usually modified bed rest with bathroom privileges encourage the client to engage in activities that can be completed in bed or on the couch. Strict bed rest can have adverse effects. Encourage the client to rest in the left lateral position to increase blood flow to the uterus and decrease uterine activity. Tell the client to avoid sexual intercourse. Ensuring hydration. Dehydration stimulates the pituitary gland to secrete an antidiuretic hormone and oxytocin. Preventing dehydration prevents the release of oxytocin, which stimulates uterine contractions. Identifying and treating an infection. Have the client report any vaginal discharge, noting the amount, color, consistency, and odor. Monitor vital signs and temperature. Chorioamnionitis should be suspected with the occurrence of elevated temperature and tachycardia. Monitor FHR and contraction pattern and fetal tachycardia, which is a prolonged increase in the FHR greater than 160 a minute, can indicate infection. This frequently is associated with preterm labor. Medications. Nifedipine. This is a calcium channel blocker that is used to suppress contractions by inhibiting calcium from entering smooth muscles. Monitor for headache, flushing, dizziness, and nausea. These usually are related to orthostatic hypotension that occurs with administration, and it should not be administered concurrently with magnesium sulfate or immediately following a beta-adrenergic agonist. Client education is slowly change positions from supine to upright and sit until dizziness disappears. Magnesium sulfate. Classification and therapeutic intent. It is a commonly used tocolytic that is a central nervous system depressant and relaxes smooth muscles, thus inhibiting uterine activity by suppressing contractions. Magnesium sulfate reduces the severity and risk of fetal neuroprotection in surviving infants if administered when birth is anticipated before 32 weeks of gestation. Contraindications for tocolysis include active vaginal bleeding, chorioamnionitis greater than 34 weeks of gestation, and acute fetal distress. Do not use concurrently with nifedipine. Do not give to clients who have myasthenia gravis. Monitor the client closely. Discontinue tocolytic therapy immediately if the client exhibits manifestations of pulmonary edema, which includes chest pain, shortness of breath, respiratory distress, audible wheezing and crackles, and productive cough containing blood-tinged sputum. Monitor for adverse effects such as hot flashes, diaphoresis, burning at IV site, nausea, vomiting, drowsiness, blurred vision. Monitor for magnesium sulfate toxicity and discontinue for any of the following adverse effects: loss of deep tendon reflexes, urinary output less than 30, respirations less than 12, pulmonary edema, severe hypotension, or chest pain. Administer calcium gluconate or calcium chloride as an antidote for magnesium sulfate toxicity. Terbutaline, a beta-adrenergic agonist that is used for a tocolytic that relaxes smooth muscle and inhibits uterine activity. Nursing actions. Assess for history of cardiac disease, pre-gestational or gestational diabetes, preeclampsia with severe features of eclampsia, severe gestational hypertension, hyperthyroidism, or significant hemorrhage. If the client has any of these, the medication should not be administered. Monitor for chest discomfort, palpitations, dysrhythmia, tachycardia, tremors, nervousness, vomiting, hypokalemia, hyperglycemia, and hypotension. Notify the provider of a heart rate greater than 130, chest pain, cardiac arrhythmias, myocardial infarction, blood pressure less than 90/60, or pulmonary edema. Administer 2.25 subcutaneously every 4 hours for up to 24 hours. Discontinue if the client can't tolerate adverse effects. Bechamethasone is a glucocorticoid that is administered IM in 2 injections 24 hours apart and requires 24 hours to be effective. The therapeutic action is to enhance fetal lung maturity and surfactant production in fetuses between 24 to 34 weeks gestation. Administer bechamethasone 12 milligrams IM for 2 doses 24 hours apart. Ideally, administer at least 24 hours before delivery. And administer deep IM using ventral, gluteal, or vastus lateralis muscle. Monitor for maternal hyperglycemia and assess the preterm infant's lung sounds. Report findings of pulmonary edema. Pre-labor rupture of membranes and preterm labor rupture of membranes. Pre-labor rupture of membranes is PROM. It is the spontaneous rupture of the amniotic membranes prior to the onset of true labor. Preterm labor rupture of membranes is preterm PROM. It is the pre-labor spontaneous rupture of membranes after 20 weeks of gestation and prior to 27 weeks of gestation. The risk factors are infection, prior preterm birth, shortening of the cervix, second or third trimester bleeding, low BMI, copper or absorbic acid deficiencies, and tobacco or substance use. Expected findings. Client reports a gush or leakage of clear fluid from the vagina. Assess for a prolapsed umbilical cord, abrupt FHR variable or prolonged deceleration, visible or palpable cord at the introitus. Lab tests. A positive nitrogen paper test, blue, pH of 6.5 to 7.5, or positive Ferning test is conducted on amniotic fluid to verify rupture of membranes. Nursing care. Nursing management depends on gestational duration if there is evidence of infection or an indication of fetal or maternal compromise. Prepare for birth if indicated. Obtain vaginal or rectal cultures for Streptococcus batis hemolytic. limit vaginal exams, provide reassurance to reduce anxiety, monitor FHR, obtain a CBC, perform daily fetal kick counts, and notify the nurse of uterine contractions. Adhere to bed rest with bathroom privileges. Medications. Ampicillin. Ampicillin is an antibiotic used to treat infection. It is commonly used to treat chorioamnionitis. Nursing action. Obtain vaginal, urine, and blood cultures prior to administration of antibiotic. Betamethasone. Betamethasone is a glucocorticoid that requires 24 hours to be effective. The therapeutic action is to enhance fetal lung maturity and surfactant production in fetuses between 24 and 34 weeks of gestation. Administer betamethasone 12 IM for 2 doses 24 hours apart. Put it in the ventral gluteal or vastus lateralis muscle at least 24 hours prior to birth. Monitor for hyperglycemia. Complications. Infection, particularly chorioamnionitis, is the most common complication of preterm prom. Other complications: placental abruption, umbilical cord compression or prolapse, fetal pulmonary hypoplasia, and death. Client education. Depending on gestational age, treatment is conservative, and hospitalization can prolong pregnancy while monitoring for risk factors. Adhere to limited activity with bathroom privileges. Hydrate. Conduct a self-assessment for uterine contractions. Monitor for foul-smelling vaginal discharge. Avoid tub baths. Abstain from intercourse. Take temperature every 4 hours when awake and report a temperature that is greater than 100.